It's really nice to be here with you all, and I think we've heard today the theme of connection and the theme of partnership come through strong in every single one of the discussions thus far. And I want to shout out here, just from my own perspective, one of my first bosses, Jan Levinson, is here on the board. So I've worked at CCA, C3, Boston Children's Hospital, and I'm currently working for Mass Aging Access there, Betsy over there. And I tried to work for Marta at one point, but she didn't give me the job that I applied for. So thanks for, giving me the token facilitator role instead, Marta. All right. Well, here I am anyway. So anyway, no big deal. We're talking about LTSS workforce and technology and what is there to say about that? It feels like a pretty intimidating topic, so I'd like to start by first just doing some basic definitions, because I've seen people filter in and out of the sessions. Very basic. LTSS, long-term supports and services, are the stuff and the services that help people stay at home. We're going to keep it broad for the perspective of this discussion. And we're also going to keep our discussion about the technology broad. It could be remote patient monitoring. It could be telemedicine. It could be the robotics idea that the prior panel threw out there. It could be AI. Whoever knows what that means these days. It's going to be all broad. And we're not going to limit our solutioning to either technology or workforce. It's going to be kind of a blend of both. So we've heard a lot of really great background information already, and I'm not going to go through any of the statistics that I had prepared to today. We'll just anchor it in the why. Why are we talking about this topic today? Firstly, everyone agrees, if you've come here today, that LTSS services are critically important to keeping people who want to be in their home. Secondly, there's more people who need them. Thirdly, there's less workforce to supply them. And fourthly, our funding is threatened, and it's making us think about all these innovative ways to do things differently. I wish I had a magic wand. I actually do have a magic wand at home, being deeply nerdy. And as it is the season for waving it around and dressing like a wizard, which I don't do, I'd like to think that there was an easy way to solve all these issues, but there isn't. And that's why we're here today, bringing together all of these different sectors to help think about what is the solution. So at this point, I'm going to open it up to a panel discussion, and I'll be feeding them some questions, which I had helpfully written down by the people at Somerville-Cambridge. So we'll just get started, and we'll see where the conversation takes us. And I would encourage the panelists to, if you have a comment or a question, or, you can't withhold your enthusiasm from what each other is saying, weigh in. It's supposed to be a conversation. We'll get there. Okay, so the first question for everybody, and if you could just briefly, again, say your name and introduce the sector that you represent when you're answering the question, is a small one. What is the most urgent challenge we need to address right now regarding the LTSS workforce? And what do you see as the biggest barrier? Bronwyn.
Thank you. Can you hear me? Is it on? Okay, wonderful. Thank you so much for being here. It's such a thrill. You can hear me? Okay, and I was here last year, and I still am raving about the forum from last year, so I'm really pleased to be a part of this. My name is Bronwyn Keefe. I didn't have to travel far. I'm right here at BU, School of Social Work down the road, and I run CATER, which is the Center for Aging and Disability Education and Research, and the focus of my work is really around developing the workforce. We've been doing this for 20 years, at our center. We really wanted to reach people that were not getting traditional forms of education, because we know that the LTSS workforce is pretty broad and has a lot of different complexities in terms of roles and in terms of the backgrounds that people have. So the goal of the center is really to build the competency and the confidence of this workforce nationwide. And boy, am I glad to be incubating here in Massachusetts, though. I don't think we would be here for 20 years as a self-sustaining center if it wasn't for the fact that we are centrally located right here. So in terms of the why now, my lens is obviously going to be workforce, right? And I'm going to repeat things that we may have already heard, so forgive me, but maybe reinforcing is good, right? The more we hear, the more we can embed it in our head. So why now for the workforce? Well, the demographic reality is clear, right? So we've already heard all the statistics about population is going to be doubling in the next 20 years. We know that this is going to continue to stress the LTSS landscape and workforce. At the same time, we know that this workforce is shrinking. Many people are retiring or aging out, and there isn't the pipeline of people coming into these jobs, right? So, and there's a lot of turnover in the direct care workforce, which I know we'll talk more about. 50% turnover annually is not uncommon. So there's a lot of turnover, there's people retiring, and there aren't enough people coming into the workforce. And I can tell you from the School of Social Work where I sit, there aren't a lot of students raising their hand saying older adults are the people they want to work with. And that's really disheartening, and I spend a lot of my time trying to convince them that this is the population they want, because they'll say health, and I'll say, well, if you're working in health, you might be working with older adults or people with disabilities, so let's talk about this. But this just, to me, brings back to the point why what we do at the center is so important, because we really are trying to train people where they're at, because it's not happening at the school systems or in the academic programs, so we've got to get it somewhere else. The other factor that's really important in terms of why now is the burnout and economic insecurity that's impacting the workforce. So people are leaving for better paying jobs, right? And despite the fact that there's been wage improvements, particularly here in Massachusetts, people are looking for other jobs that might provide better wage and more stability. So really the convergence of the demand with the aging population, the workforce attrition, and the ongoing systemic barriers are really why I think it's time, we all would agree that it's time is to act now, right? And I believe that accessible, well-supported training and clear career pathways and ladders can really help build the trajectory in building a resilient workforce. So that would be my why.
50% turnover from year to year?
Well, I'll let our experts next to us,
Okay.
it may have changed, but there's definitely high turnover.
Good thing we're all here to try to help.
Hi, everybody. Can you hear me? Okay, great. I'm Lisa Gorgoni. I'm very happy and honored to be here among so many familiar faces and friends, honestly. So thank you. I guess for me, won't be very long. I just want to say, for me, the biggest issue right now and why now, and as many of you know, I've been in this space, the workforce space, for over 20 years, is the immigration challenges we're facing. You know, immigrants are the heart of the home care, especially, and also I know I'm stealing poor Alyssa Sunder here, the nursing home workforce. We have never had, in my 20-plus experience, kind of the negative rhetoric. It's so funny. I remember, you know, couple years ago, we were talking about negative rhetoric towards immigrants. It is so much worse now. And those people are the ones that are serving our older adults. They always have been for the 25 years I've been in this space, and they will continue to. They come here, they are caregivers, they want to help people, they want these jobs, and now they're being demonized. And to me, that is the biggest challenge we have for the long-term care services sector. They come here to work, support their families. They're really hard workers. I often say, I have children and they're 18-year-old children and a lot of friends, and none of them would do the work those immigrants come here to do. So that's our biggest challenge, and I'm just very, very concerned about where we're at as a nation with this work.
Hi, I'm Alyssa Sherman. I'm president of Leading Age Massachusetts, and we are an association of not-for-profit providers of housing and services for older adults across the whole continuum. So our members include everything from skilled nursing facilities and assisted living and retirement communities to affordable senior housing and home and community-based services and kind of everything in between. And our members are really focused on making sure that all older adults have access to the services that they need when they need them in the place they call home. And clearly, you need a strong workforce in order to be able to do that. And so I will just echo really it's exactly what I was going to say, what Lisa said, that, in terms of, the long-term care workforce has really always been challenged and in crisis. And certainly, I think the pandemic exacerbated any of the issues that we had, where we saw people really leaving the workforce, especially RNs and, who we've lost. But we're at a real inflection point right now, and I would say especially it's urgent with the immigration changes that we're seeing. The elimination of the temporary protected status, TPS, especially, for Haiti, which is a huge population here, in Massachusetts. We have about 348,000 individuals on TPS from Haiti. And we know that the healthcare sector, the TPS holders are disproportionately represented in the healthcare sector and in long-term care and home care. So, these are positions we're talking about: CNAs, home health aides, dietary, housekeeping, individuals, long time dedicated employees, many who, again, came in during COVID, did the hard work, are the backbone, were the families when a lot of our, our nursing homes had to close their doors to families. They were the ones who were there day in and day out. And we are going to be losing these individuals because they are losing their work authorization, because supposedly it is now safe to go back to those countries, which we know that is not the case. We have some of our members who are expecting they may be losing 10% of their workforce because of the termination of TPS, and not to, just also the chilling effect that we're seeing that, the ICE actions are having, where people are frankly afraid to even show up at their jobs because of fear of what's going on. So all of this, unfortunately, we know will lead to reductions in access and care. And we've already seen what's happened in with hospitals being unable to discharge because they can't send people to nursing homes and there's no home care workers. So this is really a continuing crisis, unfortunately, that we really need to deal with.
Hi, is it on? Hi, everyone. I'm Shabnam Fakhrosini. I'm a research scientist from MIT Age Lab. My work focuses on two aspects of a broader challenge: technology and user. How we think of new technological solutions, how to understand needs of people, and how to design better systems and technologies, specifically smart home technologies for older groups. And then the user aspects, what really drives these people to accept and adopt these technologies and bring to their daily lives. So in the Age Lab, we think about we think about the space, the home and the environment. And recently I saw a report from NIC, National Investment Center, from a report from 2025 that said we need around 1 million new units in senior living communities by 2040 with current penetration rate. And that was really interesting because as we see what's happening now and the challenges that they are facing with workforce shortages, high turnover rates, the quality of services, we need to think about how we are really designing these new 1 million units and other spaces, private homes for people, how we can really think about existing technological solutions that can really reduce the burden from caregivers, can make older adults more independent, how we can provide a safer space, at the same time how we can, with these technologies, connect them to outside services and their loved ones. So these are some of the topics that we are working on. And this is really exciting. I'm honored to be here and talk about this. Thank you.
Hi, everyone. My name is Connor Walsh. I'm a faculty member at Harvard in the School of Engineering. And so we started a new initiative called the Harvard Move Lab. And really what we're trying to do there is kind of understand challenges in the area of human performance, broadly defined. So we do a lot of work on assistive technologies or rehabilitation technologies for people with disabilities, and how we develop technology to help people, get better. And I would say early on, we were often thinking about how do we make these technologies work well in a clinical setting. We work with BU Sargent College, Terry Ellis, Lou Awad, Diane Dalton there in kind of physical and occupational therapy. So really kind of what's happening clinically and how do we use technology to kind of augment that. But, through the kind of, and the way that we do that is we have kind of multidisciplinary teams. So we try and form teams of, mechanical engineers, electrical engineers, software engineers, working with kind of a person with a clinical background or physical therapy background or a biomechanics background. So they're multidisciplinary, cross-institution kind of expertise. And then the other thing is that I can say this because I was a graduate student once. Graduate students are very good at making things work well once. But when you have... But when you have human-centered technologies that you are developing and you really want to test in the real world, you can't have things that just work once, and you can't always have the graduate student or the engineering there. So I think a big challenge in innovating in this space of human-centric technologies is you have to develop product-level prototypes to then test and iterate and learn from. And industry doesn't really do that because they don't take on the high-risk ideas. Academia is not good at doing that because you can't develop high technology readiness technology readiness level prototypes. And so we're trying to bridge that gap by kind of combining staff expertise, so product development, technical, development expertise alongside the graduate students and the researchers who are kind of working on the early stage ideas and development. So that's the gap we're trying to bridge. And then with the pandemic, when that came along, that really disrupted our research because oftentimes we're bringing people into the lab, we're testing devices. So then we started to think about should we be trying to do more rehabilitation at home or developing technologies for the home? So that's kind of how kind of our research has evolved. And so I can mention later kind of a few examples of what we've worked on. But when I think about this is an area that is not so, I'm not too experienced in, kind of elder tech or age tech. It feels like there's a really big opportunity. That's kind of the way I think about it. You just hear today about the size of the problem. You hear about the dollars and the costs that it takes to kind of have someone go into a home and what families need to pay for that. And so as an engineer, you're if I add up that money, I'm pretty sure we could develop something that would allow someone to stay at home. But I think the big challenge is we're really just not sure what to develop. And it's not easy to develop the solutions. I don't think there's any there's no low-hanging fruit. There's existing Zoom technologies. I think that's something that has progressed a lot. Now you have telemedicine, telehealth, and I think that's not perfect, but it's much better than it was in the past. But I think the kind of solutions about how do you enable someone to move from room to room, how do you enable someone to transfer on their own, how do you help people to kind of feed themselves on their own? These are really, really hard problems, and the solutions are really, really not obvious. And so I think that's what I see as the biggest challenge is the solutions aren't obvious. So how do we figure out, some concepts and then explore those together?
Wow, that was great. I think we heard a couple of themes. The first being, the people to do the work are few and far between. And therefore, we need to think about ways to upskill and train the people we do have. And we have to think about how technology, at the same time, can help us do the work differently. Not to replace the humans, but to assist the humans, to further the reach of the humans. And in and of itself, how to begin that work is complicated. So we'll dive in a little bit. I'm going to turn it to Bronwyn first. You're really working on training and upskilling the workforce. From your perspective, what do you see as the core reasons of people leaving the LTSS workforce outside of the immigration issues, which we'll get into a little bit later? And how do you think training and advancement pathways will help address the issue?
Is it still on? Yes? Okay, great. Thank you. So, yeah, so I guess I feel like we're talking a lot about challenges, so I do want to be sure that we will talk about opportunities, because I do think there is, like Dr. Cohen, you had said, a lot of opportunity space here, and we're in the right place to do this. So, but I will start with the question, which is, what are some of the challenges? We know that this is a diverse workforce with many different roles that are encompassing the LTSS workforce, and yet they share a lot of commonalities in terms of some of the challenges. So one of the first challenges, and I think we already alluded to this a little bit in terms of the direct care workforce, is really about burnout. So, the direct care workforce has a lot of very physically and emotionally demanding job, and that really is amplified by the fact that there is not sufficient support or staffing, and I know that both you will get into some of the nuances of the issues around immigration and otherwise. And also for care managers and case managers, I mean, they are asked to do a complexity of different roles, and they have high levels of cases. So, I love the story about Lara, that she really was, that she felt like that was her one person. And amazing that she can do that when you know that they're balancing multiple people at one time and holding so much in their lap. So that really, burnout is a challenge across the spectrum. Economic insecurity is also a challenge. And again, I mentioned already where Massachusetts has increased the minimum wage. That's great. But these positions are still undercompensated when you think about the amount of workload and the amount of competency and expertise that we're asking them to take on. And case managers really have a different type of compression in the sense that they're not being paid commensurate with other roles in healthcare fields. So it's really lacking retention benefits, opportunities for people. So all of this really amplifies in terms of the economic insecurity. And then I think, what I'll get into is sort of a little bit more is that the systemic issues around a lack of a visible and structured career pathway that cross LTS roles. So unlike nursing and other fields, there may be more clear career ladders or places that you may be able to move to and from. And that's not necessarily the case in some of these roles, that people may not feel that they're able to move into other positions, either due to not having a certain degree or due to not having a certain type of experience. So there may be some barriers in terms of how people move throughout different roles. So to me, where I sit from my vantage point, I think the training and career advancements pathways are really what the solution is, or what one of the many opportunities and solutions are around really thinking about how to develop well-designed, accessible training programs and career ladders, because I think those are powerful tools for both recruitment and retention. And I think it does so in multiple ways when you're thinking about the workforce. Comprehensive training can really enhance your competencies and your confidence. And when people feel more confident in what they do, they may feel less stressed, and they may feel that they can deal with the demands a little bit more. So it's really empowering the workforce as much as we empower the clients we're working with. We all need to feel empowered also. And then with career ladders, I think it really sends a clear message, that we believe in the workforce, and that can improve job satisfaction. So people feel that, somebody's investing in me and it's important, and therefore I see a place where I can grow and how I can continue to do what I want to do in this field. So I think being able to have these clear pathways, obviously an ideal would be economic incentives along with it. So as you move along these pathways, you're seeing your income increase, or you're seeing that you're getting, more for the work that you're doing and for the degree or the information and knowledge that you are learning along the way. So I think that training really has a powerful impact. And particularly, again, here in Massachusetts, I just love the fact that so much of what we've been able to do at the center has really been able to partner with the state around incubating a lot of different workforce development programs. And so we should be, in terms of like what we're proud of, like, wow, Massachusetts has really put a big effort into workforce development. And, you know, right now we've been working with AGE for many years, but for the past 5 years, AGE has made the commitment to the ASAPs and the senior centers to provide training through CADER, our case management certificate and our behavioral health and aging certificate. This is also an opportunity for case managers to use this as an educational waiver, so they're able to get positions that they might not have been able to get because they have this additional credentialing. And I'll talk a little bit more as we get on about what I think is really the power of these reciprocal relationships between academia and other state units and other community-based agencies. And I really mean reciprocal, like bold, right? There's nobody's coming in with better expertise. We all have to work together. We all have our place. We're the, you know, what'd you say, uncommon bedfellows maybe in some ways, but, you know, everybody coming together. So I think the other thing I just wanted to mention was another really unique program that I've been involved with, and this is something that Tri-Valley Elder Services, or Tri-Valley Inc., out in Western Mass, created. So I was their partner. They created this. They got a grant. It's called the Case Management Accelerated Training Program. Has anybody heard of CMAT in this room? A couple people, yay. Okay, so the funding is now over. I just put in a grant to try to get more funding for this program, but it's a wonderful program. And so Tri-Valley really wanted to figure out how to deal with this workforce shortage, right? We don't have enough case managers. We don't have enough people that can fill these positions. The restrictions are high in terms of you have to have a bachelor's degree, you have to have some experience and able to get the work or get the job. So they developed this really comprehensive sort of 3-month program where you took some courses from CADER, and they worked with other academic partners, so there's a wide range of different educational programs, and then they went in the field and they shadowed a case manager, and they worked there and got direct experience. And so the people, just to give you an example of the people coming into this program, I think the graduates were about 60 to 80 people over the term of the grant. 85% of those people entered the program with 1 year of case management experience, and none had a bachelor's degree. So they would not be eligible for a case management position, right? Most of them were actually coming from either direct care or from lived experience as being a caregiver, care partner. At the end of this intensive training program, at the end of the job shadowing, they had a career fair, and they did this at the 5 different cohorts, and everybody pretty much walked away with jobs. And 90 days later, they found that 88% of the graduates were employed in health and social service roles, and almost 80% were employed as case managers. Again, a group of people that would have had barriers to these types of jobs. So this is a clear example of career pathways, and I think the importance and the powerful impact that we can have when we invest in our workforce. So I guess I'll stop there and let you pick it up from there. Yeah. Thanks.
Yeah, I think it's Alyssa, actually, with the next question. We're gonna bring it all together at the end, but we're gonna switch issues slightly right now to talk about the immigration issue and advocacy issues. So I'd ask Alyssa, in your role at Leading Age and in your organization, what are the challenges and how are you addressing them?
Great. So I think we talked a little bit earlier about, you know, some of the most immediate changes that we're seeing with immigration and you know, the loss of positions that, you know, we're going to see that we've already started to see and within the next month. But you know, even longer term, we've heard the demographic issues earlier, that, you know, we have this growing aging population, older adults who will need care, with a shrinking population of those who will be able to care for them. And right now we have, you know, 1 in 4 long-term care workers are foreign-born, and in nursing homes it's about 30%, a little less in other roles, and that's nationally. Even in Massachusetts, the numbers are slightly higher. So the bottom line is that we know we will need to rely on you know, immigrants, foreign-born workers, for our aging services workforce. That is just, it is a given. We will have to do that. And so, you know, advocacy right now is really critical, both for kind of the short term and the long term. On the short-term issues on TPS, Senator Warren, grateful to our delegation here in Massachusetts, and Senator Warren's taken a lead, penning a letter with over 100 other members of Congress, to the Department of Homeland Security and Department of Labor and Health and Human Services, basically talking about what it's going to mean for the loss of these workers on access and cost and quality, and really raising awareness of the economic contribution that these individuals make, and really trying to halt, there's obviously court cases, and, trying to, put off the loss of these programs. Leading Age has partnered, has joined together with the American Business Immigration Coalition, which is a coalition which has brought together different sectors that are heavily reliant on an immigrant workforce, including healthcare, agriculture, hospitality, construction, and bringing these sectors together to advocate and raise awareness of the critical role that immigrants are playing in our workforce and our economy, and how our economy really relies heavily on making sure that we are providing clear pathways for people to be able to be here and work legally, and providing them the supports also that they need to be able to do their jobs. And so there's some legislation that the American Business Immigration Coalition, and I encourage people to check out this coalition, because it's great. I know that they had a big event last week in Washington where we had some of the Leading Age members participated, and they were working together with dairy farmers who are being able to advocate for recognizing also the needs for older adults. And so it was this great kind of cross-sectoral approach. But, there's some key pieces of legislation that, they're really hoping to gain traction on. One is the Dignity Act, which will provide legal status to long-time undocumented individuals and permanent residency for those who entered the U.S. as minors. The Healthcare Workforce Resilience Act, which would recapture 40,000 unused visas, 25,000 of which are designated for nurses, and to help reduce the EB-3 green card backlog. And then the Essential Workers Advancement Act, which would propose the creation of new H-2C non-immigrant visas for non-degreed, non-seasonal workers such as nursing assistants, home health aides, and personal care workers. So all of these, again, right now we know the climate is unfortunately, not welcoming, but we really need to have everybody advocate to realize, what it will mean if we do not have these essential workers being able to provide these jobs, and what it's going to mean for older adults and individuals who need services. And so that it's a story, back to the what we heard this morning, stories, that people need to be able to tell the stories of not being able to access care, and how the critical role that immigrants play in the long run. I would also just say in the short term, obviously there's a lot of efforts going on, just following up on some of the work, what Brownon talked about in terms of how we need to really grow the pipeline of folks who are, living here, who might not have otherwise considered a job in aging services. We created a video last year called Careers in Aging Services, really talking about the huge variety of jobs that people can do, not just those clinical positions, but, in tech and HR, and, there's a lot of different things, and talking about, the skills, that people can really use their skills in a profession where they can make a difference, and really trying to expose folks who wouldn't otherwise, know about that. And also the career ladders, how critical I think those are, creating those opportunities for people to develop additional opportunities for skills and pay. We were really grateful last year, the legislature, as part of the long-term care quality bill that I know Representative Stanley, who was here, championed, included for the first time a provision to allow for the creation of certified medication aides in nursing homes. And I think that's something that we're looking at as a career ladder, as part of a career ladder, where a CNA can go on to become a certified medication aide, develop, new skills, more responsibility, and greater pay, and that hopefully, ultimately, they may be able to move on and look at down the road LPN. So those are things that I think we're looking at also in terms of just strengthening recruitment and retention.
Thank you so much. We're going to move on to the technology space now, and I'm going to ask Shabnam, in your role at the MIT Age Lab, how do you see technology being supportive of the workforce?
So I'm going to start a little bit talking about the concept of smart home and smart home technologies, which is our main focus. We are envisioning that within the next 5 years, a lot of the homes, or maybe I should say the residences, specifically in developed countries, will be evolving into a kind of home that we call networked home. Level 3 home in MIT Age Lab home taxonomy and levels of automation. In this type of homes or residences, a lot of the devices are connected to each other and probably to a central hub or central system that allows users to manage their devices, program them through that single interface, which this step lays a foundation for the higher level, next level home, which we call it proactive home. And that's where higher levels of contextual awareness happens, where the home has higher levels of understanding of all the activities and the individual users, who is in the kitchen and using the stove, who is in the bedroom, who is coming home. And this type of understanding and capability and predictive analysis, analytics and understanding and anticipating needs is what we need to get to proactive care model, from reactive to proactive, and that's the goal for near future. And we think this is not really easy, because the integration of all these systems and capabilities, there are a lot of examples already in market we can purchase, but the interoperability, the integration of these systems, and the cost and the barriers related to people's concern about data privacy, and how much information they want to give away to all these devices, who has access to their data. So these are the things we are working, and at the same time we are thinking in this proactive care model and the environment that we are envisioning, how we are really building these technologies and designing them that they can automate the tasks in a way that we are creating good behaviors, better habits, as opposed to just automating tasks. What tasks should be automated for what kinds of lifestyle, to what extent, and considering people's living arrangement, their health condition, their caregiving availability. There are millions of scenarios within this really complex environment that requires, it's really hard to approach, because at the same time we need to design these environments that are highly customizable and are personalized environments for their users. I'm going to stop here. So this is basically some of the challenges and the solutions we are working on.
Thank you so much. Yeah, I'm intrigued. And I hope that folks stick around later to ask the panelists questions, because I'm sure there's a lot of ideas being sparked. We have two more questions to get through. Next, going to Connor, who's expert in the engineering space and speaking to grad students, is what I heard, using grad students for good. Can you share some examples about the innovations that you're working on and how they can address some of the challenges in post-acute care delivery especially?
Yeah, sure. And I think on maybe just before kind of getting into that, just reacting, I think kind of Mariam did a nice job just highlighting the complexity of the challenge. Like there's like lots of things to figure out, and it's really like a system level design challenge. And I think that's just makes it really, really hard. It's like how do all those different pieces and parts kind of work together? And I do think there's opportunity, but I definitely don't think we know what the solution is. But I'm pretty sure the solution is not a bunch of engineers spending times by themselves trying to make things and then eventually bringing them somewhere and handing them off to people. Like that's probably not going to work. So at least we know that. But I think, you know, and this kind of ties to kind of like a project we worked on, which I can use an example. I think people mentioned that it's like services and tech. I think is really the opportunity. And we think about our work more recently as like tech-enabled services. So, you know, there's a lot of services being provided, and then there's the stuff that was mentioned as well that's being kind of like delivered. So it's really kind of how you think about making that stuff smarter and how you make that stuff enable the services, you know, to be more efficiently delivered and more effectively delivered. I think that's kind of like where kind of like I think the solution space is. And I think there's real opportunities for kind of doing it across like everything, you know, the home, and I think that's probably the long-term vision in the future. But then we might also think like, are there shorter-term opportunities for specific problems or specific use scenarios where we think kind of making stuff smarter and enabling it to deliver better services is an opportunity. So one example project we worked on was for at-home rehabilitation after stroke. So, you know, before the pandemic, what would normally happen is, you know, a person who's had a stroke, if they're getting occupational therapy, they would go to a hospital twice a week. They would have to kind of travel from their home. Maybe they can drive, or someone would have to bring them to the clinic. They would have to kind of see a therapist. They would get, you know, 30 minutes of maybe kind of like stretching, kind of like our hand time. And they wouldn't really have any data to quantify, are they doing the right thing? Are they kind of getting better? So one example project we worked on was trying to think about, well, how do we enable that to happen in the home with new technology? And it was also the same time that, you know, CMS was approving kind of like remote virtual occupational therapy. So now kind of therapists could bill for that as part of clinical practice that didn't exist before the pandemic. So it's like a positive change that happened. So what we developed was basically a soft robotic glove. So basically kind of like a robotic glove that a person could wear. And then that could kind of do some of the work that the therapist would have done in the clinic. This device can also have sensors on it, so it can monitor how well a person is doing and how often are they doing it, and are they adhering to the guidelines that are being recommended. The therapist can remotely monitor that, and the therapist can remotely check in with the person. So it's actually kind of, you know, the human connection is really important, as was mentioned already. So like, it may not be as nice, you know, virtually versus in person, but if you don't have to travel and you don't have all the hassle of finding parking, I think a lot of people actually would prefer to do that at home, as long as they still had the ability to kind of connect with a therapist virtually. And that's kind of happening about sports and training and all these things at the moment as well. And so I think I would just kind of think about that as a model, like when we think about this space, like are there other areas where there's something that a person needs a person to come and do, it's maybe, you know, not the most fun thing, or there's hassle associated with it. And how do we use technology to augment that, but keep the caregiver in the loop? And that could be a family member, that could be kind of a person who's visiting the home. But I think it's really important to try and figure out together, like how we kind of get teams of people working together to kind of solve these, identify the use cases, define them really clearly, and then kind of like develop solutions. And I think you're not going to get it right the first time. I think you have to acknowledge that. It's going to take some learning that has to happen. But bringing it back to kind of the workforce development issue is, you know, we work with a lot of physical therapists, students, engineering students all the time. Getting them to work together on these projects is great, because they're often looking at things with a fresh set of eyes, and having them be able to be mentored by people with more experience, I think kind of generates kind of solutions that maybe we haven't thought about before. And it also kind of helps make sure that we're training this next generation of caregivers to also be more aware of like, how was this technology developed? So they're not just seeing technology and having to use it, but they're kind of actually kind of helping to think about it getting developed too. So I think making sure that the people who will be the end users, and that could be the older, you know, adult themselves, or the person who's caring for them, are aware that technology has been developed with them as a stakeholder in mind, I think is critically important. And I think it can lead to kind of more interesting and innovative models of education, as well as just kind of, and workforce development, as well as just the core technologies that get developed.
I too would like a robot hand. We have about 5 minutes, and not to be flippant about all of this stuff, we have about 5 minutes left, and so I'm going to introduce Lisa Gorgoni, who's our closer, to really bring it. I know you could do it. To really bring it home in the practicality of what it is really like on the ground to work at an ASAP, facing all these issues. And was there anything that was discussed today that you think would work?
Well, first of all, I want to say I love that we brought technology and workforce together, because I have so many thoughts now from that presentation from the technology people, but I also have notes on what I was going to share. So we'll kind of go all over the place. But I think there's sort of 4 things that, as a practitioner in the field, in the aging space, working with managed care entities and partners, hospitals, what we're facing as an ASAP and a AAA. And I think it's kind of 4 areas. It's advocacy, training, administrative simplification and partnerships, and innovations. So quickly, I just want to say advocacy is definitely where we all are at the moment. And I want to thank our partners here who help us in that work. I know so many of us are doing this in different levels. I do see Jay Higgins in the back from Congresswoman Clark's office. She has been phenomenal in DC in terms of advocating for Medicaid dollars and Medicare dollars. One of the things we did to help them was we actually interviewed a consumer in one of our buildings and did a little video to talk about what Medicaid means to that woman. And I think that's really important for all of us to think about. Are there ways we can, again, use our voices to make the case to those that need it, that there is need out there. And I also want to talk about the press. I think Megan was here from BUR, and I've talked to her several times about stories of people impacted by cuts, and what does that mean? Things aren't going to change if we don't advocate, and that's so many ways. It's legislative, but it's the press, it's telling stories. There's just so many ways to do that, social media. I also want to thank Senator Markey's office has a caregiving bill in Congress, which is bipartisan, which again would help support some of the caregivers out there with the tax credit. So there's so many ways we can get involved in those things on that level. Training. We are really focused on training in the ASAP AAA network. I know a lot of the SCOs are as well in OneCare. We're seeing so many behavioral health issues with the consumers that we serve on a daily basis. And I don't think we have enough training in that space. We have worked with BU on some training, but you can't give enough training to even the housing. I see Kim here from housing. The people that we're dealing with, just so many more complicated issues, and how do we train to help with that work? And then I'm going to get into the tech side, tech training, both for our teams, our staff. A lot of them have been in the space for a long time and aren't up to date, but also our consumers. I'll give an example. During COVID, we had a lot of grants, and we gave a lot of tablets to older adults. And we would find that when we went out, 6 months later, they were still in the box. And so we have what we have called the Tech Access Program, where we actually train volunteers to help train older adults on how to use technology. And it's just a kind of constant. It's not hard for them, but they just want that support. They want someone to talk to them. They want help. I know for my own mother, she asks a lot of questions, even though we've told her before, but that's fine. And I think we need to continue to do that, because I think there's so many good technologies out there, but you can't just hand it to someone and expect them to use it. You really need to support them. Let's see what I have on the other side. And then in terms of, administrative simplification, I think we're working as ASAPs as a network to think about ways we can work together. Can we share staffing? I have extra nurses. Can I give them to another ASAP, partner with them so they can use their nurses? It's kind of a way to work together more appropriately. We're working with Whitney Moyer, the COO of AGE right there, on some components to simplify the work of the frontline staff so they're not duplicating information. And actually, when the tech people are talking about that, I think a lot about shared systems. And I know in healthcare and in managed care, we talk about this. A lot of the systems don't talk to each other. So my team is entering stuff that the SCO team's entering, the hospital's entering, the PACE team's entering. How can we get the data to talk to each other? That I know is a huge barrier. It's been talked about for so many years. But if we can just not crack that nut, I think we'd save a lot of time and a lot of money, quite honestly. We're spending a lot of time re-entering data. Hospital to home is an initiative that HHS funded with some ARPA dollars where we embed ASAP staff in hospitals. And shout out to Adam from Mass Hospital Association. He was here. I know I saw him earlier. They were really supportive of us as well, working with hospitals and ASAPs so that when someone's in a hospital, we can work with them to make sure they go home with the services so they don't end up back in the hospital. And so the Health Policy Commission just funded that program through a new grant program that's going to come out. So we're really excited about continuing that. Supportive housing. So something that we did at Mystic Valley and a lot of other ASAPs have been doing, and I know, again, other housers do. We've embedded nurses in supportive housing sites. So have a nurse on site at the housing, comes for office hours. They do educational programming. I'll just tell a quick story. We had one woman who hadn't seen a doctor in 40 years. And of course, she was in the SCO, a managed care entity, and they had been asking her to see her PCP. She kept ignoring them. So our nurse was there for office hours. She started coming down, getting her blood checked, said, you know, oh, your blood pressure's high. Do you have a PCP? No, I don't have one. After working with her, it did take a few months. Now the woman has a PCP. She's on medication. She's actually, talking to the nurse when she sees changes. It made a huge difference. But again, she wasn't going to answer those calls. I could tell her a million times on the phone. She wasn't going to do it. It's going down, seeing that nurse, and the nurse working with her, baby steps. Did you call? Here's another list. Did you call? It made a difference. So I think that's all I actually had. So that's I think my closing would be partnerships.
Yeah.
I think, my whole career, and as anyone who knows me knows, is all been about partnerships. And there are so many potential partners and current partners of mine in this room. I think we can solve this problem if we all work together. And so I really am excited, and thank you to Somerville-Cambridge and Marta. She's such a visionary. And knowing that we have to come together to solve this. So thank you all for being here.